Mm-hmm. Okay. And I've got a Socrative quiz that will be going on throughout. So please do join that. Let me double check that is working. So do join. We'll be doing questions throughout the lecture and they'll be quite quick questions. Um, and people can join as we go along as well. Okay. I see people have started to join. Okay. I'll leave that up for a second. Um, Okay, so we'll be on the first few slides. So let's get started. So in cardiology, we're going to cover the endocarditis, the valvular heart diseases, and the ischemic myocardial and pericardial diseases. Okay, so let's start off with infective endocarditis. So risk factors to look out for in question stems is someone with prosthetic valves, congenital or rheumatic heart disease, and intravenous drug users, and then also hemodialysis, so people with long lines, like long-term lines, and also dental surgery can also come up. And then the order of the valves to remember is that it often affects the mitral valve, and then it's the aortic, and then tricuspid and pulmonary in terms of like most common valves affected. But for intravenous drug users, it's always tricuspid because it comes from the venous system. Okay, so it goes into the right side first. And then here's a quick table summarizing the common organisms that affect in endocarditis. So we have in acutely, it's usually Staph aureus and also the coagulase negative staphs as well. So like Staph epidermidis. And then we have the 2 months post-surgery. So there's a dental link, the Viridum streptococci, with native valves. You can read them here. And then intravenous drug users is often Staph as well, Staph aureus. So let's go on to our first question. So a 34-year-old man who injects heroin presents with fever, shortness of breath. Examination reveals a pansystolic murmur, loudest at the left sternal edge that increases on inspiration. The blood cultures grow Staphylococcus aureus. Which valve is most likely affected? Okay, so hopefully, if you've joined the Socrative, you'd be able to answer and then see if you got it right or not. So do join. I'll come back with feedback too and an explanation. I'll give you a few more moments for some more people to join. I know it's the day after Tingewick, so might be a bit tiring. People are joining. So yeah, the answer to that one was tricuspid. As we know, it says that he is a person who injects heroin, so an intravenous drug user. Later on, we'll cover why it's louder on inspiration, because it's a right-sided valve that's affected, and a pansystolic murmur as well is also a clue that it is a tricuspid valve. Okay. Now we have another question. So this one is a dental procedure is followed by a low-grade fever and weight loss. The organism is likely. Oh, let me move it on in the Socrative. Nice. It's strep viridans, so that's just the one often after dental work for some reason. And for the other ones, I think it says the reasons for the other ones as well. Okay, that's just one quick one to remember. And then one last question. So persistent bacteremia with an indwelling line, which one would that be? Let me move this along. Okay, so that one is staph epidermidis, so a coagulase negative staph. So they're usually on the skin, so they colonize the lines. Okay, so signs and symptoms of endocarditis. We have cardiac signs include a new murmur, and again reminding you that it's usually the mitral valve first, and then the aortic, tricuspid, and pulmonary. The extracardiac signs you might have learned in the cardiac examination session. So we have Janeway lesions. Those are found on the palms and soles, and they're non-tender compared to Osler nodes, which are found more on the fingers and toes, so like more extremities, and they're also painful, so they're tender. And then we also have splinter hemorrhages, and that's what they look like, and they're just found in the nail beds that you can look for. Um, okay, and then diagnosis involves multiple blood cultures, so more than two over 12 hours apart. And then it's also diagnosed with echocardiography looking for vegetation on the valves. Um, and it mentions here that transesophageal is usually better than transthoracic echocardiography. And note that it's the Duke criteria for diagnosing endocarditis that might be tested. So here's a quick question again. Let me just move it along. Oh, I've just been logged out. There we go. Found it. Here's the next one. Okay. So a patient has painless erythematous macules on their soles, splinter hemorrhages, and positive blood cultures. Which feature is most specific for infective endocarditis? So this question is kind of testing you reading the question carefully because there's a lot of features of endocarditis here. So yeah, so it is quite confusing, but it's Janeway lesions. Those are the most specific ones, whereas splinter hemorrhages are non-specific. Um, Splintered hemorrhages can also be from some vasculitis, antiphospholipid syndrome, and then also some other autoimmune diseases. So that was the kind of trick here. Janeway lesions are the most specific ones. Okay. So here's the two criteria. I've just put it in here for revision. But the main thing is blood cultures, so over 2 and over 12 hours apart, and then echocardiographic evidence. Okay, I can read through that. And then here's a quick revision slide on endocarditis. Okay, you can also read through that later. So valvular heart disease, that's next. So valves can have stenosis. So that means they're scarred and there's resistance to flow. They don't open properly. Incompetence, meaning that there's backflow through the valve. It doesn't close properly, doesn't have a tight seal. And then it can also be both. So left-hand side lesions are more common, so mitral and then aortic valve again as the most common ones. So let's have a look at aortic valve disease. We have aortic stenosis. Um, so causes of aortic stenosis include senile calcific. So um, when you get older, the valves calcify and then become stenosed. And then we also have people with bicuspid valves, bicuspid aortic valves, and they are usually younger, so they just calcify earlier. So if you read the stem and there's like a slightly younger patient with aortic stenosis, you could think about them having a bicuspid valve, and then also rheumatic heart disease. So the signs are slow rising pulse, a narrow pulse pressure, a left ventricular heave and aortic thrill, deep displaced apex beat, and then an ejection systolic murmur. So here's the picture here, and it's a systolic murmur. And then I'm not sure if this is often heard, but reverse splitting of the second heart sound. And the symptoms for aortic stenosis are angina and then syncopes and also dyspnea, so shortness of breath. And the severity is often in that order. So if they're getting short of breath, it's often getting worse. Okay. Well, I've got an acronym later to help you remember the murmurs and when they happen. Okay, so we also have aortic regurgitation. So the bicuspid valve can also lead to aortic regurgitation, rheumatic heart disease, endocarditis, and also hypertension and Marfan's, often causes of aortic regurgitation. And then signs include the collapsing pulse, so that test that you do when you lift the arm up, so the water hammer pulse, a wide pulse pressure, and then an early diastolic murmur, and then a displaced apex beat as well, due to the ventricle often being dilated. Here we see this diastolic murmur occurring in diastole, and then symptoms also include dyspnea, palpitations, angina, and head bobbing. That probably won't come up, but that's aortic regurgitation. Mitral stenosis. So mitral stenosis is common in chronic rheumatic heart disease. And signs are a mallow rush, so flush. So this butterfly shape, like redness on the face, atrial fibrillation, and also it seems like right side heart failure, a mid diastolic murmur with an opening snap, so a mid diastolic murmur. And then we have a low volume pulse and peripheral cyanosis. And then here are the symptoms again. Okay. And then we have mitral regurgitation. So again, rheumatic heart disease. We have mitral annular calcification, so like the mitral ring being calcified, a ruptured papillary muscle, which can happen after an MI, mitral valve prolapse, endocarditis, and dilated cardiomyopathies. So the signs are a displaced forceful apex beat, a pansystolic murmur, and then sometimes an atrial fibrillation and signs of left-sided left ventricle dilation. Okay, and then symptoms are also quite similar again, often when it's quite bad though. Okay, so right-sided heart valve disease. So for tricuspid valve disease, the JVP is raised. We see in stenosis, tricuspid stenosis, it's from rheumatic heart disease, endocarditis, and then also carcinoid syndrome. Tricuspid regurgitation, endocarditis, right ventricular dilation, and then congenital, so Epstein's anomaly. Yeah. And then pulmonary valve disease is rare. Stenosis is often congenital, like tetralogy or Fallot, and then regurgitation, pulmonary hypertension. But these ones are rarer to come up. Okay. And then hypertrophic obstructive cardiomyopathy. It's an autosomal dominant disorder. It causes asymmetric septal hypertrophy. So it's often on one side and leading to left ventricular outflow obstruction. and you hear a harsh ejection systolic murmur, which is increased with any Valsalva maneuver. Exam, you can hear a double apex beat, and then it's often the cause of sudden cardiac death in young people. Okay, that was a very quick run through of those. And here's a summary page. That's good for revision. And then this random, what's it called? Mnemonic that's come in, that can come up, that can help is ASMR, so aortic stenosis and mitral regurgitation. Those are systolic, and I just remembered it because ASMR, like systolic, I don't know. And then arms is diastolic, and you have two arms or something like that. So aortic regurgitation and mitral stenosis are both in the diastolic phase. That's when you hear the murmurs. Okay. And then Ryle, you might have come up as so with right-sided valves, the murmurs are louder on inspiration, and then the left-sided ones are louder on expiration. Okay, questions. Okay, there's the next Socrative question. A 68-year-old man has a slow rising pulse, a narrow pulse pressure, and an ejection systolic murmur radiating to the carotids. What would the diagnosis likely be? Yeah, everyone got it right. So it's aortic stenosis. Nice. Okay, another one. Patient with a history of rheumatic fever develops malaflush and then tapping apex beat and a mid-diastolic rumbling murmur with an opening snap. What would the diagnosis be here? Nice. So it's mitral stenosis. So that rumbling diastolic murmur and then that opening snap as well. And then malaflush is a key sign for mitral stenosis too. Okay, one more, I think. So this patient has a collapsing pulse, a wide pulse pressure, and early diastolic murmur. Yeah, nice. Okay, so yeah, that's aortic regurgitation. So the diastolic murmur and also that collapsing pulse. So the water hammer pulse. Okay. Oh yeah, another one. So which finding suggested tricuspid regurgitation? So, oh, let me move the question along. Yeah. Which finding suggested tricuspid regurgitation? Antisystolic murmur. And because it's on the right side, it would be increased with inspiration. Okay, so rheumatic heart disease. Um, it most commonly affects children aged 5 to 15. It occurs 2 to 4 weeks after group A streptococcal pharyngitis. So um, it's caused because of an autoimmune mechanism, antibodies against strep pyogenes, cross-react with cardiac tissue. So in the acute phase, myocarditis can cause arrhythmia, and then in the chronic phase, the inflammation can lead to valve scarring and fibrosis, and it's often mitral and then aortic. Okay. The acute episode can last around 3 months. It's treated with antibiotics to eliminate the streptococcal antigen, and then recurrences in the future with other group A streptococcal infections. So they might need prophylaxis. And then key histology is Aschoff bodies, so granulomatous nodules in the myocardium. So if you have in the question stem a child with a recent sore throat and then cardiac sort of symptoms, think rheumatic fever. Okay, so early on, myocarditis, and then chronically, there will be valve fibrosis. And then diagnosis of rheumatic heart disease is with the Jones criteria. Okay, so they sometimes test you on the names of these criteria. Okay, and then let's go on to ischemic heart disease. So risk factors for ischemic heart disease include the non-modifiable ones, so men are more likely to have it, age, so older people as well, and then family history. So first degree relative with premature ischemic heart disease. So if someone's father had it at under 60, that would be a positive family history. And then there's also the modifiable risk factors. So smoking, hypertension, diabetes, dyslipidemia, obesity, and stress. Those are all contributors to ischemic heart disease. So, so acute coronary syndrome. So we have stable angina, which is not part of acute coronary syndrome. Acute coronary syndrome has unstable angina and an N-STEMI, so non-ST elevation MI, and then a ST elevated MI. And then a myocardial infarction are just these two. And they have a troponin rise because there has been damaged tissue, damaged muscle as part of it. Let's go through them. So, stable angina is not part of acute coronary syndrome. So, we have the presentation of a crushing or heavy chest pain radiating to the jaw or left arm that is worse on exertion, but it can be relieved by rest or GTN spray. And then atypical presentations can also be of indigestion and toothache. And it's not part of acute coronary syndrome because it's associated with exercise and exertion and can be relieved. Whereas unstable angina, it's a new onset angina with increasing frequency or severity, and there is pain at rest and or minimal exertion. So there's no like sort of reason for it. It just starts happening, meaning that the artery is more occluded, so more occluded than stable angina, and it is not relieved by GTN spray. However, there is no troponin rise in unstable angina, which is what distinguishes it from an NSTEMI because there's no damaged tissue. So ECG changes in acute coronary syndromes. So we have unstable angina, and there is some potential ST depression, T-wave inversion, or it can look normal. But the key thing is there is no troponin rise. Non-ST elevation MI could be the same as unstable angina, but troponin is positive, showing that there has been some myocardial necrosis. And then there's ST elevated MI. So there is ST elevation in two contiguous leads. So it'll be, I don't know, two leads that are near each other, or like represent areas of the heart that are near each other. And then there could also be reciprocal ST depression in the areas opposite the location, and then also troponin will be positive here. because there's full thickness ischemia of the myocardial tissue. So, quick question here. So, chest pain that is exertional, relieved by rest, and also radiates the jaw. What is this one? Yep, so this is stable angina. It's quite predictable and the pain stops with rest. Okay, the next one is there is chest pain at rest. It's not relieved by GTN. The ECG looks normal. Troponin is negative. Yep, so here you see chest pain at rest that is not relieved by GTN. So that kind of rules out stable angina, which isn't an option. And then we have the ECG being normal, so there's no ST elevation there. And then troponin is negative, so that kind of this because troponin is negative, it's likely it's unstable angina. If troponin was positive, then it would be an N-STEMI and not non-ST elevation MI. So yeah, unstable angina. Okay, and then some myocardial infarction histology. Um, so you see in the early hours, so 24 to 48 hours, you see neutrophilic infiltration and then coagulative necrosis. And then from 1 week, it starts healing. So there's granulation tissue with fibroblast proliferation and collagen deposition. And then weeks to months later, you can see scarring, so dense fibrotic scar, and then loss of myocytes. Um, yeah, I think early on, um, the histology is that the myocytes look very wavy. Okay. And then complications of an MI afterwards. So this can come up in questions. So 1 to 2 days afterwards, there can be an acute pericarditis, and the key thing to note with that is that they might have symptoms of pleuritic pain, so pain on inhalation. And then there's also from 1 to 2 weeks, there's free wall rupture, leading to tamponade as well. So symptoms of that, sudden shock and acute heart failure. And that's because it's granulation tissue forming, so the wall is weak. And then the 2 to 6 weeks is Dressler syndrome, so an autoimmune pericarditis. And then over 4 weeks will be left ventricular aneurysm, so a persistent ST elevation, also S3 and S4 sounds, and then crackles you can hear. Okay. So myocarditis. It can be caused by viral causes, so Coxsackie virus, adenovirus, and influenza, drugs, autoimmune causes, so lupus, sarcoidosis, and then post-transplant rejection. It often presents in young patients, presents with chest pain and dyspnea, can mimic an acute coronary syndrome, and then sometimes associated pericarditis as well. So, myocarditis is the inflammation of the myocytes, so the heart muscle being inflamed here. And then diagnosis can be with ECG, so T-wave inversion, but notedly it's the increase creatine kinase MB and increases in troponin and increase in ESR and CRP, so inflammation, and then echocardiography and MRI as well there. Okay, so that's myocarditis. Then we have pericarditis. So here the words that you note in the question would be pleuritic chest pain that is worse lying down and better sitting forward. You can hear a pericardial friction rub, and sharp inspiration increases the pain, and then also shortness of breath and a cough. So causes of pericarditis can be viral, could be due to uremia, and then also post-MI acutely, and also as Dressler syndrome, which is later on, which is autoimmune. And then TB can cause constrictive pericarditis. We'll have a quick look at that. And then we have ECG showing a saddle-shaped ST elevation. This came up in an OSCE last year, actually. So saddle-shaped ST elevation, and then troponin might be mildly increased, and then echo will show pericardial thickening / effusion. And then bloods kind of determine what the cause of it can be. Okay, so constrictive pericarditis is when there's scarring of the pericardium leading to it being more rigid and then that impairing the diastolic filling. So the symptoms can be of fluid overload and also general heart failure symptoms. So a raised JVP, Kussmaul sign, so increased JVP on inspiration, pulsus paradoxus, and pericardial knock. So kind of like a tamponade syndrome as well. And the management is a pericardectomy, so just to relieve the pressure. Okay, quite a filled slide on my cardiomyopathies. So hypertrophic cardiomyopathy we kind of covered. It's often the cause of sudden death in young athletes. There's myocyte disarray, obstructive physiology, and then it's the harsh systolic murmur with increased with Valsalva maneuver. We have dilated cardiomyopathy, so dilated left ventricle, heart failure symptoms, and cardiomegaly as well can be seen on X-ray. And then causes of it include alcohol, cocaine, pregnancy, viral, chemotherapy, hypertension. Yeah. And then we have restricted cardiomyopathy, so also heart failure symptoms. And this time, because it's kind of restricted, the atrium are larger, so there's biatrial dilation and then deposition. So you can see amyloid, iron, or granulomas inside the myocardium. So symptoms of right heart-sided heart failure and left-sided heart failure there. We have cardiac tamponade. We have, oh wow. Okay, so it's a life-threatening emergency. The Beck's triad, so hypertension, raised JVP, and muffled heart sounds. Those are the three key what's it called, symptoms of cardiac tamponade. And then other features include pulsus paradoxus, an over 10 millimeter mercury drop on inspiration, and then the patient looks very unwell as well. And that also needs relieving of the pressure. Okay, aortic dissection. Risk factors include hypertension. So aortic dissection probably should have included a picture, but it's just the tear in the lining and then blood goes through the intima and media, creating a false lumen. So we have type A in the ascending aorta, which is a surgical emergency, and then in the descending aorta, it's okay. This can be managed medically. And the symptoms is a tearing chest pain radiating to the back, to the shoulder, back or shoulder, and that's often in the question stem. Okay, and then there's the abdominal aortic aneurysm. So an over 3 centimeter width aorta in the abdomen is an aneurysm. And then surgery is recommended at 0.5 to 6 centimeters. And then they're often asymptomatic until rupture, which is why there's a screening program for it. And then unruptured symptoms is a pulsatile abdominal mass and back pain, but it's often asymptomatic. And then once it's ruptured, very severe back pain, shock, syncope, and collapse. Okay. This is a summary of the sort of pain you could feel with each of these, just as a quick summary. Okay, question 11. Okay, another question. Let me go to So, which MI complication presents 2 to 6 weeks post MI with fever and pleuritic chest pain that is worse lying down? Yeah. So you've identified that it's a pericarditis due to the pleuritic chest pain that is worse lying down. And because it's occurring 2 to 6 weeks post MI, it's likely Dressler syndrome, so an autoimmune cause, whereas acute pericarditis occurs 1 to 2 days after an MI. Okay. And then question 12, a young man presents with chest pain following a viral illness. Troponin and CKMB are raised. The question along. Yes, this question is quite vague. Okay, so we have a young man and chest pain following a viral illness. And then I think the key thing to note here is that CKMB is raised, and that's often a sign for myocarditis. So yeah, myocarditis, and it's following a viral illness, which is quite common too. Okay, next question, which is a 60-year-old male chronic smoker presents with mild chest pain and shortness of breath 2 weeks following an episode of severe chest pain for which he sought no medical attention. ECG shows persistent ST elevation. This one's a trickier one. It's more cryptic. So, um, yeah, quite cryptic. So we have a 60-year-old male chronic smoker presents with mild chest pain. So he has mild chest pain and shortness of breath. And it's following an episode of severe chest pain, which he sought no medical attention. So the severe chest pain was supposed to mean an MI, which he did not seek medical attention for. And then this new chest pain that is continuing suggests a left ventricular aneurysm. And because ST elevation is often a sign, persistent ST elevation is often a sign for left ventricular aneurysm too. Okay. Okay, so hopefully that's okay for cardiology. And then we move on to biochemistry. So fluid balance, potassium handling, acid-base balance, blood gas results, and then endocrine biochemistry. That's what we'll try to cover. Okay, so this is the total body of water distribution for an adult. Yes, you probably have covered this in undergrad, all of this, so hopefully this is clear. And then osmolality is particles per 1 kilogram of solvent, and then osmolarity is particles per 1 liter of solution. So osmolality is often used, but then osmolarity is calculated by 2 times the concentration of sodium plus urea plus glucose. Yep. And then we have fluid distribution. That's controlled with Starling forces. So we have the venous tone, which determines the hydrostatic pressure. We have the oncotic pressure, which is protein driven. So this changes if there are lots of protein loss or increase in protein in the blood for some reason. So causes of edema, so tissue, blood fluid outside of the vessels include increased capillary hydrostatic pressure, decreased plasma oncotic pressure, so for example, low albumin, and then increased capillary permeability and decreased lymphatic drainage. So these are the causes of fluid in the wrong place. Okay. So hormonal control of fluid balance. We have ADH, the anti-weeing hormone. So this is very responsive, it acts on the V2 receptors to increase aquaporins in the collecting duct and so leading to water reabsorption. So anti-weeing. And then we also have aldosterone, which is triggered by hypovolemia, and it causes the renin-angiotensin-aldosterone system to work. So it also acts on the collecting duct, increased sodium absorption, reabsorption, and potassium excretion. We have diabetes insipidus, which is the failure of ADH. I think the name has changed now to something like low ADH, something like that. And the symptoms are dilute urine and fluid loss. Okay, so symptoms are polyuria and polydipsia. So the types we have are nephrogenic, so when the kidney doesn't respond to ADH, which can be caused by lithium, for example. And then we have cranial diabetes insipidus, which is there is no ADH production. And then psychogenic as well, which is excess water intake. And that can be tested with the water deprivation test. And here are the urine osmolarities you can have a quick look at, but this summarizes diabetes insipidus. We have primary aldosteronism, which is around cause about 10% of hypertension cases. So if they have hypokalemia and are also having resistant hypertension, so not responding to treatment, then you need to think about hyperaldosteronism. So Conn syndrome, which is an adenoma releasing aldosterone, and then bilateral adrenal hyperplasia. So the investigation here, that's a key bit, is the aldosterone-renin ratio to check that. That's often a question. Okay, and then Addison's disease, primary adrenal insufficiency. So there's autoimmune destruction of the adrenals, and then so there's reduced glucocorticoids and reduced mineralocorticoids. Features are hyperpigmentation, often of the palm, and then face, and then also weight loss, fatigue, and hypertension. And here is the short synactin test. So they get given ACTH, and there's no cortisol rise. So it's not a problem with the hypothalamus releasing ACTH. Yeah, no pituitary. Okay. And then hypernatremia. So that's when the sodium is over 145 millimoles. So this doesn't really come up, hypernatremia, but I've found a table of the potential causes of hypernatremia. So we'll quickly move on to hyponatremia, which is sodium when it's less than 135, but it's often symptomatic at less than 120. And this can be quite serious. So the first thing to check is the osmolality to make sure that it's not pseudo-hyponatremia. So if the osmolality is normal, it confirms that it's an artifact. So if there's a high lipid or protein in the blood, then there is a pseudo-hyponatremia. So severe hypolipidemia and myeloma can cause pseudo-hyponatremia on blood tests. So important to check osmolality. So, and then once you've checked the osmolality and it is low, then it's likely to be true hyponatremia. So the next step is to look at the volume status. So if they're hypovolemic, it's often due to renal losses from diuretics, for example, or GI losses. So there's fluid loss associated with the sodium loss. And if they're euvolemic, it can be SIADH, so syndrome of inappropriate ADH secretion, and then hypothyroidism. And then hypovolemic, if they look like they have edema, ascites, then heart failure and cirrhosis and nephrotic syndrome, which is when they lose all their proteins in their wee. And that can lead to water being in the wrong place. Okay, so SIADH. So it's hyponatremia and hyperosmolality. The urine is often very concentrated, um, and then, but they're euvolemic clinically. You can read up on it later, but it somehow balances out. Okay, and then causes of SIADH can be lung disease, so in TB, in pneumonia, so Legionella, and then malignancy as well. And then CNS disease can lead to SIADH, drugs, and then cancers as well. It's a very random list, but SIADH is always one to consider when you have hyponatremia. Okay, and then the management of SIADH is fluid restriction, so remove the triggers. So I guess you have to treat the causes of it, and removing triggers means like stopping the drugs. And then it's important to correct slowly, so you can't give them, yeah, you can't give them too much sodium because you can lead to central pontine myelinolysis, which is the demyelation of the pons with the destruction of myelin sheaths, which is bad. Okay, and the risk factors for these include malnutrition, alcoholism, and chronic hyponatremia. So it's important to correct slowly to avoid that. Okay, questions again. This one is on hyponatremia, actually, but what could it be? Oh, let me move the question slide. So, 70-year-old man is confused and lethargic. Sodium is at 159 millimoles. Urine output is high, very dilute. So we have very dilute urine, and he drinks large amounts of water but still appears dehydrated. Okay. Yep. So that is hyponatremia, and that is cranial diabetes insipidus. So um, the clue here is the urine output is very high and very dilute. So he keeps so ADH causes very dilute urine. So low ADH, yes. Diabetes just means lots of wee or something like that. Okay. Okay, this next one. So, a 45-year-old woman on long-term SSRIs is found confused. Labs include sodium of 118 millimoles, serum osmolality low, urine osmolality high, and then urine sodium is 40 millimoles per liter. She is euvolemic on exam. What is the most likely immediate management step? So this is 2 steps even. So have a think about what she could have. So long-term SSRIs is a slight clue. And then she is hyponatremic. And her urine is very concentrated. Yeah, I hope you've got that. The first, that she has SIADH, probably caused by the SSRIs. So we would want to stop the SSRIs as well. But out of the options here, fluid restriction would be the best one to do because salt tablets and hypertonic saline would correct it too quickly, and that would be bad, causing central pontine myelinolysis. Okay, and then another question here. So, cause associated with hypovolemic hyponatremia. Okay, nice. That one's hypovolemic hyponatremia. Oh no, what am I saying? That one's heart failure because it's hypervolemic, so they look quite fluid overloaded, and they have hyponatremia. So heart failure is the one which has a dilutional effect. Okay, a quick recap on factors controlling plasma potassium. So we have renal excretion. So the kidneys are the main regulators. Aldosterone promotes potassium secretion. So increase in aldosterone leads to decrease in plasma potassium. We have renal function. So if the kidneys aren't working, they can't excrete potassium. So in renal failure, there's hyperkalemia as well. And then there's also potassium in the body. So potassium can move in and out of cells. So leading to a decrease in plasma potassium is insulin, for example, due to the K-ATP channel, and beta-2 adrenergic activity, and alkalosis. So that's quite a useful association to remember. So alkalosis and decreased plasma potassium. It often comes up for some reason. And acidosis is increased plasma potassium. Okay. And then patterns for potassium and ECG. So hypokalemia, you see flattened or inverted T waves, so flat T waves, and ST depression. And then U waves, which is just another wave after this T wave, and that is not a P wave, so there will be another P wave after that as well. And a prolonged QT interval. So it kind of just gets stretched out with a random U wave, which is hypokalemia. And then hyperkalemia is a peaked T wave. Yeah. And a prolonged PR interval and flattened P wave and widened QRS complex. But the main thing is that tall T wave. Okay. And then refeeding syndrome occurs when nutrition is reintroduced after a prolonged period of starvation of malnutrition. So it's a sudden shift from a catabolic to an anabolic state. So everything basically goes into the cells, so leading to hypophosphatemia, hypokalemia, and hypomagnesemia. And the main one causing the symptoms is hypophosphatemia. That comes up in questions too. So hypophosphatemia is the one causing the bad things in refeeding syndrome. But there's also hypokalemia, hypomagnesemia. Basically, everything is low. Everything has gone into the cells. And then in the high risk groups are people with anorexia, alcoholism, chronic malnutrition, so cachexia from cancer, elderly and post-ICU, so people who have had prolonged starvation and malnutrition. So refeeding, need to monitor them and do it slowly. So magnesium is essential for potassium retention. So important to check the magnesium levels when dealing with hypokalemia. So that's just something to check. Okay, another question. So we have a patient with type 2 diabetes and chronic kidney disease, presents with muscle weakness. So the labs are potassium 6.5. Okay, I forgot to put the normal values in, but so that's high. It's hyperkalemia. Normal sodium and normal bicarbonate. And then ECG shows peaked T waves. Okay, so here we have the answer being hyperaldosteronism. Um, yeah, big. Um, how I remember the effect of aldosterone is spironolactone is a potassium sparing one, and spironolactone is an antagonist of aldosterone receptors. So aldosterone must be potassium losing, which is a long-winded way of thinking of it, but there we go. So hyperaldosteronism will lead to increased potassium, so it will keep the potassium in the system, whereas sorry, all the other options will lead to no, hypokalemia. Okay, quickly, acid base, we have buffers, bicarbonate, and hemoglobin as a buffer as well. Um, yeah, here are some quick things on acidosis and alkalosis. Um, Not too important, I think. So let's quickly move on. So, how to interpret ABGs? We have to first check the pH. Is it acidosis or alkalosis? And then for figure out if it's respiratory or metabolic. So we check the PCO2 and the bicarbonate and see if it matches or doesn't match the acidosis or alkalosis. So here is the Rome mnemonic. So if respiratory is going opposite. Wait, let me think. Oh yeah. So if the CO2 is high and the pH is low, then it's likely a respiratory cause. And metabolic causes, they are aligned with the bicarbonate, with the pH. Okay. Which kind of makes sense because CO2 is an acid and then bicarbonate is a buffer to the system. And then you can, once you figured out if it's initially a respiratory or a metabolic cause, then you can see if there is compensation or not. Okay, let's have a quick go here. Move it on. So we have an ABG here, and the pH is 7.24. So I'll let you guys have a quick look at that first. Yeah. think you're getting it. So pH is low, so it's an acidosis. And then we have let's looking at the CO2 and the bicarbonate. So we have CO2 being high, showing that because its opposite is likely a respiratory cause. And we have bicarbonate here as high as well. So it's trying to buffer. So it's actually partially compensated the respiratory acidosis. So slight compensation there. Hope that is okay. Yep. So let's keep on going. So respiratory acidosis, there's high PCO2 and a low pH. Because CO2 retained becomes carbonic acid. So causes of that include COPD and airway obstruction, so in severe acute asthma as well. Um, and then in in opiates and CNS depression, so you're also not breathing out as much CO2. There is also respiratory acidosis, neuromuscular disease, chest wall disorders, and severe pulmonary disease. So just cases where you're not expelling the CO2. Okay, alkalosis is low PCO2 and a high pH. So there's excessive loss of CO2. So from hyperventilation, anxiety and pain, which is also hyperventilation, I guess. And we can also have it from overventilation, so iatrogenic causes. Um, yeah, kind of causing the alkalosis on purpose in ICU sometimes. So here's a quick summary of those. And then with metabolic acidosis, it's useful to calculate the anion gap, and you calculate that by adding the cations and then minusing the anions. So with the normal being 10 to 20 millimoles per liter. So with a high anion gap, it's usually caused by something else in the body that's not normally there, increasing, making it more acidotic. So lactic acidosis from sepsis, for example, ketoacidosis, toxins, so methanol and salicylates, and renal failure. And then we have normal anion gap causes. So this means that the cause is something that's normally found in the body that's at a wrong level. So, for example, too much hydrogen in the body causes an acidosis. So, with decreased hydrogen secretion, that causes and as metabolic acidosis. And then if we have excessive loss of bicarbonate, that's also a cause of metabolic acidosis. And then we have hyperaldosteronism as well, for example. And these are the types of renal tubular acidosis. So we have the distal cause, which is type 1, and then the proximal problem, which is type 2. And that one is something to remember. Okay, metabolic alkalosis is a high pH with high HCO3, so bicarbonate. As you see, those are aligned, so that is from like the earlier example of how to work out if it's a metabolic or respiratory alkalosis or acidosis. Okay, and the causes of metabolic alkalosis include GI acid loss, pyloric stenosis, diuretics, alkali ingestion, and mineralocorticoid excess. Okay, another question on this. So we have a pH that is high and a really high bicarbonate. So we have a high bicarbonate, suggesting that the primary cause is metabolic alkalosis. And then we also have quite slightly high carbon dioxide as well, suggesting a bit of hypoventilation to compensate. Okay, yeah. So next question. We have a 55-year-old with sepsis, and then here it shows a pH that is quite low, low bicarbonate, and then low carbon dioxide, and the anion gap is 22. So the anion gap here is quite high, um, because sepsis causes that with lactic acidosis, um, and pH is low, so which is an acidosis, yeah, and low bicarbonate too. Okay, I'm going. I think there's like 10 slides left, so we'll go quickly. So, calcium dysregulation, hypocalcemia. Symptoms include perioral paresthesia, carpopedal spasm, seizures, and laryngospasm. So hypocalcemia somehow decreases the what's it called? Like nerve firing. So lots of spasms there. And then calcium. High calcium is bones, stones, moans, and psychiatric overtones. So bone pain, nephrolite, so kidney stones, abdominal pain and constipation, and then also just tired, slightly depressed. Control of calcium includes the parathyroid hormone. So parathyroid is released from the parathyroid glands in response to low serum calcium. So it increases bone resorption. So osteoclasts. Oh, yeah. It stimulates the osteoblasts, which release rank L to stimulate the osteoclasts, which then break down the bone and increases the calcium and phosphate in the body. And then in the kidney, it increases the calcium resorption, increases vitamin D, and decreases the phosphate. Okay, yeah, decreased phosphate reabsorption. Then we also have vitamin D. So here's the process of activating vitamin D. Vitamin D acts on the bone and also the gut as well. And these work to have calcium homeostasis. So we have hyperparathyroidism. There can be primary hyperparathyroidism where there's high PTH, high calcium, and low phosphate. And then secondary parathyroidism is due to low calcium. So it's kind of a response to the low calcium, leading to high parathyroid hormones. And then in tertiary parathyroidism is after long-standing secondary hyperparathyroidism. So basically after, for example, chronic kidney disease leads to low calcium, so there's a high parathyroid responding to it. And then after the person gets a kidney transplant, the parathyroid organs keep on releasing the parathyroid hormones, still leading to tertiary hyperparathyroidism. Okay, and then here's a quick summary of calcium phosphate and ALP in these diseases. Okay, then vitamin D deficiency, lack of sunlight, poor intake, liver disease, chronic kidney disease, and then some drugs as well. Then in children, it presents as rickets, and then in adults, it's osteomalacia. Okay. Um, Here is another question. Um, Nearly at the end now. So, primary hyperparathyroidism. So, parathyroid, um, yeah. Okay. And then we have a patient with CKD stage 4. So he has low vitamin D, low calcium, high phosphate. What is the expected biochemical response from parathyroid glands? Yes. So this person would have secondary hyperparathyroidism due to the low calcium. Okay. And then we have one more question. We have a patient presents with bone pain and proximal muscle weakness. So they have low calcium, low phosphate, and high ALP. What's the most likely diagnosis? Yeah. So this is likely from low vitamin D. Okay. I think this is the final slides. Okay, so we have primary hyperlipidemia. So the most important thing to remember here is familial hypercholesterolemia. It's a mutation in the LDL receptor, and you just have really high cholesterol. And then something that's pathognomonic is tendon xanthomatous. And then we have secondary hyperlipidemia. So high cholesterol, high triglycerides, both high, caused by these things as well. But often tested as familial hypercholesterolemia. Okay, I have gone over time, but here is a quick summary of everything, and these slides will be shared after. Sorry for the rush, all at the end. Okay, so this is the QR code for the feedback slide, and hopefully you will also be able to get the slides after filling it in through your email. Oh yeah, you'll get a copy of the slides after you've filled in the feedback, and then Divya will send them out to you later on, likely tomorrow. Yeah. A link to the form. I can try get that. Yeah. Okay. I've just sent a link to the form on the group chat. Yeah. Once you've done that, that's all done for today then, and there will be another session tomorrow. Okay. That's all done.